We want to welcome all of you to the New Hampshire Insurance Department's annual hearing on premiums in the insurance market. Our hearing is an opportunity to present findings on the insurance marketplace and create a forum for any related topics. Let's quickly take care of some housekeeping. Coffee and snacks are available just outside the door. We'll take another break at 10:10, and all those snacks will still be out there for you. Restrooms are just about 50 feet down the hall this way. There's 3 of them that I noticed down there. Today's event is being recorded and is being viewed through internet live stream. Next, I would like to recognize the following staff from the department. Alex Feldwebel, he's right here. Tyler Brannon had to leave pretty quickly for a family emergency. Hoping to see him back. Al Kuchar, yep, there he is. Jennifer Patterson is over here. David Skye is right here. Michael Wilkie. Maureen Mustard. Ariana Spell. There she is. And project manager Martha McLeod. There she is. And I noticed Christy Rice here is our director of HR, and that's mostly to keep Alex in line. So I wasn't supposed to tell her she was here. I'd also like to recognize some staff of Gorman Actuarial. Jenn Smagula, right here. Don Gorman, and Linda Keene. There we go. The department has released a preliminary report developed from data received, and a final report will be available early in December. The reports can be obtained from our website. There's also a 2-page summary of the report finding, and it's available in the area where you came in. Additionally, we have copies of a Wall Street Journal article on hospital deals and consolidation. That article is relevant to the discussion during the carrier panel, and that is also available right outside. We're going to begin with a presentation by Gorman Actuarial on health insurance premiums and our insurance market. After the Gorman presentation, we will hear directly from our carriers. The carrier panel will focus on consolidation in both the insurer and provider industries. After the carrier panel, we hope to have a presentation by the department on carrier provider discount study. This is an analysis of the discounts obtained by carriers in New Hampshire and provides insight about the competitiveness of the marketplace. A public comment period will be permitted at the conclusion of the department presentation. Okay, let's get started. First, I'd like to introduce Jenn Smagula, who will present the annual hearing findings for Gorman Actuarial. Jenn?
So I'm Jenn Smagula. I'm a healthcare actuary working with Gorman Actuarial, and I'm joined here today by Don Gorman and Linda Keene. And I'm going to take you through this presentation on the key findings from our preliminary report on New Hampshire's 2017 healthcare premium and claim cost drivers. So the goal of the report in the presentation is to examine health insurance premium and claims costs and the factors contributing to changes in those costs. This year's focus is on 2017, but we'll also be presenting some information from 2018. So first, to start with an overview. The uninsured rate in New Hampshire has decreased almost 5 percentage points from a high of 10.7 in 2013 down to 5.8% in 2017. So during this same time period, the United States uninsured rate has also experienced a similar decrease from a high of 14.5 down to 8.7, but the U.S. uninsured rate remains higher than the New Hampshire uninsured rate. And this chart also points out some of the significant impacts to the New Hampshire health insurance market over the past several years. So this includes the implementation of many of the major provisions of the Affordable Care Act, which happened in 2014, Medicaid expansion in New Hampshire, which happened in August of 2014, and then the conversion of the Medicaid expansion population to the Premium Assistance Program, or New Hampshire PAP, on January 1st of 2016. So as of that January 1st, 2016 date, all of those Medicaid expansion members became part of the commercial individual market, and they were rated under the single risk pool requirements of the ACA. So they were included as part of the individual market rating pool. Individuals eligible for the New Hampshire Premium Assistance Program generally include adults aged 19 to 64 with incomes up to 138% of the federal poverty level who aren't otherwise eligible for Medicaid or Medicare. So, and as we'll discuss more further in the presentation, there's a couple changes that have already happened or are going to happen in New Hampshire that will impact the New Hampshire health insurance market. So one that's already happened is the closure of Minuteman in 2018. So Minuteman was a lower costing option in New Hampshire that primarily served the individual market. And the second change is the migration of the New Hampshire PAP population out of the commercial insurance market to the Medicaid MCOs, which will happen in 2019. Now, this first change, the closure of Minuteman, could result in an increase in the uninsured rate in future years based on what we've seen so far in the early 2018 data, and we'll see some of this information in upcoming slides. So these next couple slides compare New Hampshire or average New Hampshire premiums to other states and to the U.S. average. So this first slide looks at the individual market and uses publicly available data from the CMS risk adjustment reports. So in 2015, New Hampshire individual market average premiums were about 4% higher than the U.S. average. So the blue line, the blue bar is New Hampshire, the red line is the U.S. average. Now, looking ahead to 2017, this relationship has switched. So New Hampshire average premiums were 19% lower than the U.S. average, and they were actually ranked 10th lowest across all states. Now, in the U.S., the average premium increased about 21% from 16 to 17, and consequently, total enrollment in the U.S. decreased. So total enrollment in the individual market in the U.S. decreased about 10% from 16 to 17, and that was driven by about a 20% decrease in those members who do not receive any type of subsidies, the members who are paying the full premium. Now in New Hampshire, from 16 to 17, we saw about a 6% increase in individual market premiums, and the 2017 enrollment did not change very much. But again, looking ahead to 2018, where we are already seeing in New Hampshire membership decreases as premiums increase, this relationship between the New Hampshire and how it compares to other states in the U.S. might change. So this next slide looks at the small group market, and it's using the same publicly available information from the CMS risk adjustment reports. So in 2015, New Hampshire small group market average premiums were about 6% higher than the U.S. average, and they ranked 10th highest across all states. And looking ahead to 2017, New Hampshire small group market average premiums were about 2% lower than the U.S. average and ranked 20th highest. Average premiums in the U.S. increased about 4% from 16 to 17, which was very similar, only slightly higher to what we saw in New Hampshire small group. Those premiums increased about 3% from 16 to 17. So now this slide compares the large group average single premiums in New Hampshire to the U.S. averages and to other New England states. So CMS risk adjustment does not apply to the large group market, so we don't have that same data available to us, but here we're using data from the Medical Expenditure Panel Survey, or MEPS. So the United States is colored in black, New Hampshire is colored in red, and then the other New England states are showing up in other colors. So this shows that in the large group market, New Hampshire is consistently higher than the US average premiums, but they're in the mid to lower end when you compare them to other New England states in 2017. Now in 2017, New Hampshire premiums were about 3% more than the US average. Maine has the lowest premiums of all the New England states in 2017, and Rhode Island and Connecticut had some of the highest average premiums in this market at about $7,000 per enrollee per year. And note that the premiums shown here and throughout the report include both the employer part that the employer will contribute to the premium and the employee contribution. So these next two slides that I'm going to show you also use MEPS data, but now we're shifting our focus. Instead of looking at premiums, we're looking at average deductibles. So deductibles are one form of cost sharing that's common to many healthcare options. So this shows that in the small group market in New Hampshire, single deductibles are significantly higher than the US average. They're about 45% higher in 2017. And they're consistently higher than most other New England states. So Maine's average deductibles, that line in blue, they're following pretty much in line with New Hampshire, while Massachusetts and Rhode Island have some of the lowest average deductibles in this market. And this last slide in this section shows, now does a comparison of New Hampshire large group deductibles to the US and other New England states. So in the large group market, New Hampshire deductibles are about 20% more than the US average in 2017. New Hampshire and Maine, Maine again is in blue, they consistently have higher average deductibles than the other US states, which is similar to what we saw on the small group slide. Now the scales on this slide and the slide I just showed you, so the scales are the same. So this just kind of looking at both of them gives you a sense that the small group market, first of all, generally has much higher deductibles than the large group market. They go up as high as $3,500. But also there's much more variability in the small group market. The spread of deductibles by state is much wider. When you look at the large group market, it's a much tighter range. All right, so we are now going to move on to talk about some coverage shifts. And by coverage shifts, we mean we're looking at shifts in enrollment within the health insurance market, and these could be shifts by market segment or by insurer or just overall. So this slide gives an overview of the New Hampshire commercial insurance market from 2015 to 2017. And by commercial, we mean people who purchase insurance either on their own or they receive it through an employer. So on the left, this is a gray bar that shows the proportion of membership for each commercial market segment in 2017. So note that almost half of the insured commercial market, or the 48.9, which is that bottom gray bar, they're enrolled in large group self-insured plans. Now, similar to prior years, we see that the majority of membership is getting their health insurance coverage through their employer. So this consists of that large group self-insured market we just talked about, the large group fully insured market at 19.8%, and then the small group market at 12.6%. So the right side of this chart in colors shows the enrollment by market segment over the past 3 years. So for instance, the New Hampshire PAP market, which is that second gray bar down, they were new to the commercial market in 2016, and they're currently at around 42,000 members, or about 8% of the total commercial market. So as of January 1st, 2019, that's the population that will no longer be part of the commercial segment. Now, another item to note is enrollment in the small group market has decreased from 2016 to 2017. So that's that third set of colored bars. Membership there has decreased about 7%. And the small group market consists of those employers with 50 or less employees. So this slide takes a closer look at the small group market where we saw the membership decreases, and it looks at market share by insurer. So while overall membership in the small group market is decreased, we can see that market share for Anthem Matthew Thornton, which is shown in blue, has stayed pretty consistent at 44%, while Harvard Pilgrim has grown their market share in this segment from 46 to 50%, and their Harvard Pilgrim shown in red. Now, Tufts was a new entrant to this market in 2016, and we can see that they are gaining market share. They're the purple piece of the pie in 2017 at 5%. Now, on the flip side, Community Health Options exited the New Hampshire market in 2017. So you can see their market share going from the 9% in that light blue to nothing in 2017. So Community Health Options, or CHO, was a lower costing option in this market in New Hampshire that was available in 16. That's no longer available. So small group employers may have dropped coverage when CHO was no longer available. And our data also shows that the decreases in the small group market are coming primarily from the 2 to 25 segment, so employers with 2 to 25 employees, so the smaller of the small groups. And we know that CHO was more highly concentrated in that smaller of the small group segment. So up to this point, we've been focused on membership and information through 2017, but now this takes a look at what's going on into 2018. So this slide compares membership from April of 2017 as of April of 2018. And when looking at this data, we see there's about a 10,000 membership decrease in the individual market segment during this time frame, driven by a loss in the non-exchange portion of the individual market, so the red piece of the pie. And those are the members who they're not receiving any type of subsidies. They're full paying members within the individual market. Now, due to the high premium rate increases that occurred in the individual market in 2018, and knowing that with the closure of Minuteman and them being a lower costing option in 2017, many enrollees may have dropped their health insurance coverage during this time or tried to find it elsewhere. And one item note is that when you look at the small group and large group segments, they've actually been fairly stable so far based on what we've seen into 2018. So we've shown this slide in the past, but we feel like it's a good way that really demonstrates how diverse the individual market is and all the different subpopulations. So this slide starts with the 94,000 members who are in the individual market as of April 2018, and it shows all the different breakouts. So for example, on the left-hand side, we see the 10,000 non-exchange members, and then it further breaks it out into 6,000 of those members are part of the grandfathered transitional population, and 4,000 are part of the non-grandfathered population. So those 6,000 grandfathered transitional members, they are not part of the single risk pool that we've talked about. They are rated separately from everyone else in the individual market. Now, on the right-hand side, we start with those 84,000 members who are getting their health insurance through the marketplace exchanges. That includes 41,000 who are in this New Hampshire PAP population, and then another 43,000 who are not in the New Hampshire PAP population but could still be getting other federal subsidies. So of those 43,000, we can see 18,000, they're getting cost-sharing reduction subsidies and federal premium subsidies. 15,000 are not getting the cost-sharing subsidies, but they're getting the premium subsidies. And the remaining 10,000 are they're purchasing coverage on the exchange, but they're not getting any type of subsidy. So the segments outlined in blue, these are folks who are not getting any type of subsidies, and the segments in green, they're getting some type of subsidy for their coverage. So this slide gives another view of the changes that we're seeing in 17 into 18. So consistent with the previous slide, the bars shown in green are getting some type of subsidies, and that includes the New Hampshire PAP population, and the bars in blue are not getting any type of subsidy. And it's in the blue segment where we're seeing the largest membership decreases. So in 2017, we see about 23,000 people in those two blue bars who are not getting any type of subsidy, and that decreases to about 14,000 in 2018. So due to these shifts among the population, the individuals receiving subsidies, the percentage of individuals receiving subsidies is increasing. We can see that in 2017, about 74% of this market are getting some type of subsidy, and that increases to 84% in 2018. Now, this slide uses data from the all-payer claims database in New Hampshire, or also known as the New Hampshire CHIS database. And it looks at each of the insurers who had the majority of the individual market membership, excluding the PAP folks for a minute, and it looks to see what happened to them in 2018. So in the case of Minuteman, which is on the right side, we can see that about 35% of those Minuteman members who were in the market as of 2017, 35% of them have dropped health insurance and are no longer have health insurance benefits in New Hampshire. The remaining 65% of those Minuteman members did find health insurance elsewhere. A lot of them we can see did shift over to Anthem, Matthew Thornton. Now with Harvard Pilgrim, which is shown on the bottom right in red, they also had a fairly large portion of members drop coverage. About 24% of them dropped coverage. 38% found coverage elsewhere, and the remaining 38% in the solid red stayed with Harvard Pilgrim. And then lastly, the top left, we have Anthem. So they experienced the smallest amount of members dropping coverage completely. Only about 10% of their members left the market. So given the number of members who have dropped coverage so far in early 2018, it is expected that this will eventually impact the uninsured rate. And also knowing that Minuteman attracted the healthier risk members, and it's the Minuteman members who are left at the highest rates, it is expected that eventually this is going to play out in higher claim cost trends. So this chart looks at the increase in the second lowest costing silver plan from 2017 to 2019. Now, rates and rate changes for the second lowest costing silver are often reported as this plan represents the benchmark plan for which premium subsidies are based off of. So from 2017 to 2018, the change in the second lowest costing silver was about 78%. Now, the change in the second lowest costing silver from 18 to 19 came down 15%. So the overall, this translates to a change of about 51%. And what's driving that decrease from 18 to 19, a big part of it is due to the fact that in 19 is when the New Hampshire PAP population has migrated out. So that's causing a lot of the decrease. But still, when you look at this over this 3-year period, that's an overall rate increase of 51%. and the rate levels in 2019 are still much higher than 2017. So it's not anticipated that the members who left in 18 are going to come back in high numbers to this market, given how price sensitive this market is. So the last slide in this section is going to shift our focus to the large group market and the mix between fully insured and self-insured business. So the primary difference between a self-insured and a fully insured arrangement is that under a self-insured arrangement, it's the employer who assumes the risk of the healthcare claims of its members, while under a fully insured arrangement, it's the insurer that's assuming the risk of those members, and they charge a risk premium in order to take on that risk. So when an employer is making a decision about whether to self-insure versus fully insured, some of the questions they'll consider is that employer large enough to smooth out the volatility in healthcare claim cost expenditures? And is that employer able to absorb an unexpected high-cost claim? And lastly, will the savings that the employer expects under a self-insured arrangement, is it enough to take on all that added risk that comes with the self-insured arrangement? So as shown by this chart, each insurer's strategy does vary. So Cigna, for instance, their primary focus in New Hampshire is the self-insured segment, which is shown in red. So about 92% of of Cigna's large group membership in New Hampshire is from self-insured. Now, Anthem, they have more of a mix. About 70% of Anthem's membership is self-insured. The rest is fully insured. And then Harvard Pilgrim, it's more split, half and half. But overall, we see that within the large group segment, about 71% of the membership is self-insured. And note that state regulatory agencies like the NHID have very little rating authority over self-insured business. So now we're going to look at data for premiums and cost sharing in New Hampshire. So this slide gives a picture of what happened to premiums within the various segments in New Hampshire over the past 3 years. So overall premiums in the fully insured market have increased 6.7% from 2016 to 2017. When you look at the individual market on the left, they experience a premium increase very similar to what they've seen in the past, so the 6.2 and the 6.8. The small group market premium trends have come up from what they saw the prior year, so the 2.7 versus the prior year at the negative 1.0. And we did see in the small group market in this in the current time period, they did have benefit buy-down, so members were switching to plans with higher cost sharing, and that helped keep the premium trends lower than they otherwise would have been. In the large group market, their premium trends have also increased this year from the 4.4 to the 5.5. And in that segment, we saw very little benefit buy down. Now, based on a 2017 employer benefits survey from the Kaiser Family Foundation, average premiums in the employer market nationwide increased about 4% for single coverage and 3% for family coverage. So when comparing these to the results we're seeing in New Hampshire, they're in the ballpark. The small group market is on the lower end of that range, and then the large group premium trends are above that range, the 5.5. They're higher than slightly higher than what happened nationally. So this slide takes a further drill down into what's happening in the individual market when it comes to premiums. So again, overall premium trends in the individual market increased 6.8%, and we saw the largest increases occurring in the non-exchange and the grandfathered transitional population. So the non-exchange is the second set of bars, They saw a premium increase of 12.2, and the grandfathered transitional saw an increase of 13%. Now, the exchange population, which is over on the left, they saw an increase of about 7%, and they represent a large portion of this market. They represent about 44% of this market. Now, when we look within the exchange population, we did see a lot of shift over to Minuteman products, and again, those are the generally lower costing options that were available in 17. So that helped keep premium trends lower in the exchange market versus the non-exchange market where Minuteman didn't have as much of market share. So now this looks at average deductibles within the New Hampshire market over the past 3 years. So on the left side, we start with the individual CSR population. So CSR are the cost-sharing reduction subsidies for qualifying low-income individuals who have 250 or below 250 of the federal poverty level. So these cost-sharing reduction subsidies allow individuals to have lower deductibles along with lower co-pays and low co-insurance, and they still pay a fairly low premium. So these members on the left side, the ones getting the cost-sharing reduction subsidies, have some of the lowest deductibles in the market. So their average deductible that in this 2017 year was $1,184. So this is much lower than the deductible for everyone else in the individual market, what we've labeled the individual non-CSR folks. So the individual non-CSR folks, they have an average deductible of about $3,950, and that's about 3 times more than what the folks with the CSR are getting. Now, when comparing the individual non-CSR to the group segments over on the right, you can see that they're also higher than the group segments. So the non-CSR deductibles are about 22% higher than small group, 30% higher than large group, and they're almost 5 times greater than the deductibles in the self-insured large group market. Now, about half of that large group self-insured market, which is shown on the right, about half of that segment is made up of state and municipal plans. So looking at all the data, we can see that deductibles have increased in all segments from 16 to 17, but it's the large group self-insured segment that saw the smallest decrease. Their deductibles only went up about 1.4%. So the last slide, we are focusing on deductibles, which is just one form of cost sharing that's tied to a plan design. So this slide looks at average cost sharing that's actually paid by members in each of these segments. So it's their total out-of-pocket costs for the year. And this can include all the deductibles, but it also includes whatever co-pays and co-insurance they were also paying. So similar to what we saw on the deductible slide, we have seen that paid member cost sharing has increased in all segments from 16 to 17. And the relationship among segments is similar to what we're seeing or what we saw on the deductible slide. So the self-insured members are paying the lowest amount out of pocket per year, followed by the individual CSR, and the individual non-CSR folks are paying the most during this time period. So that individual CSR population, the second set of bars, their out-of-pocket costs represent about 25% of the total medical spend. And this compares to, if you compare them to the individual CSR, those folks are paying about 12% of their total medical costs out of their own pockets. And then again, comparing on the right-hand side the large group fully insured to the large group self-insured. The large group self-insured, what they're paying out of pocket is about half of what the large group fully insured members are paying. So the last slide in this section looks at the relationship between premium and benefit richness. So the paid to allowed ratio, which is shown on that y-axis or the vertical axis, that's an indicator of how rich a health insurance benefit plan is. So the higher that ratio, the closer it is to 100, the more rich the plan design is and the less the members are paying out of pocket. Now the x-axis or that horizontal axis, that is the premium PMPMs that were actually paid out. And each bubble in this chart represents a different market segment. So this chart is mapping benefit richness versus premiums. So for example, the dark blue bubble that's over on the right, that is the large group market, fully insured market. So they have the highest premiums because they're further along the axis. They have their average premiums are about $525. But however, they're also situated above the small group and individual CSR segments, so they have richer benefits. So they're paying higher premiums, but they have richer benefits. Now, by contrast, we have the individual non-CSR. So their premiums are lower than the other two segments in blue, but their benefits are also less rich. They're lower on this chart. Now, the two bubbles in green, those are the two segments whose premiums are subsidized, and they have other cost-sharing type of subsidies. So the New Hampshire PAP is shown way up near the top of the chart, and we also have the individual CSR. So this shows they have the most comprehensive or richest set of benefits out of all the segments within New Hampshire. So now we talked about premium and cost sharing, so now we're going to talk about actual claims costs. So trends in the total fully insured market have in total come down in 16 to 17. So last year we saw trends of around 6.4%, and they've come down to 4% in this time period. Now you can see a lot of this is driven by what happened in the individual market. So the individual market, which is on the left, they saw a really big spike up in claims trends in 16, and then it's moderated into 17. So that big spike up in claims, that was when the PAP population came into the market. Now, if you just look at the small group, large group, which is combined in the middle there, their trends have come up slightly. So they were trending at 2.8% last year. Now they're at 3.4%. And then over on the right, we're showing the self-insured segment. So they have the highest trends of all the segments in this time period at the 5.9, and their claims levels are also a lot higher than the other segments. So this chart takes that combined 3.4% small group and large group trend that we saw on the previous slide, and it breaks it into two components. So one is utilization, and the second is cost and mix. So utilization is the number of services provided, and unit cost and mix is the increase in price for those services, and increases due to the change in mix of the services or change in mix of providers. So utilization trends have actually come down slightly from 16 to 17, so the 1.2 to the 0.7, while cost and mix trends have come up, the 1.5 to the 2.7. And what we're showing on the right is when we look back over the trends for these 3 years, what portion is driven by utilization and what portion is driven by cost. So you can see it's really the cost and mix trends that are driving trends. About 88% of trend is driven by cost and mix, 12% is driven by utilization. So within that cost and mix bucket, we know from data collected from the insurers, the mix portion of that, it's fairly small. It's about negative 0.5% to positive 0.5% during this time period. So if you were to back that out, it's really the cost, the unit cost or price increases that are driving trend over this time period. And then we went back and looked even farther. We have data like this back to 2011, and it's consistent when you look over this long time frame. It's consistently cost that's driving trends. And then we compared to what other states were seeing, and even nationally, so states like Massachusetts, and then information that's available nationally. And the story is very similar. When you look over the past several years, it's cost that is driving trends. So this slide looks at which service categories are contributing most to trends over the past couple years, and this is still focused on just the group markets right now. So when we look at trends from 16 and 17, the main drivers of trend start with outpatient facility costs, followed by inpatient facility and professional services. So this is a change from what we saw when we looked at this last year, where it was pharmacy was a big driver of cost. When we looked at this last year and looked at trends from 14 to 16 in last year's report, the largest contributor was pharmacy, and it was contributing about a third to the overall trend increases. But you can see here that's given some of the trends coming down on the pharmacy side, pharmacies impacting trends about 8%. So now this slide takes a deeper dive into pharmacy and some of the different components. So, and this is we're still in the group markets right now. So pharmacy trends in 2017 were negative 0.5%, or means it was fairly flat. There was very little change from 16 to 17. And we can see a lot of this is driven by the lower specialty pharmacy trends that happened in 2017 versus 16. So last year, specialty pharmacy trends were 17.5. Now we're seeing they've pretty much cut in half. They're about 9.1%. However, as you can see, specialty pharmacy, it's still the biggest bucket within pharmacy. It represents about 41% of pharmacy costs, and their trends are much higher than what's happening on the non-specialty side. Now, the right side of this chart, this shows the pharmacy costs that are coming through the medical benefit. So this includes prescription drugs that are administered at a hospital or in a doctor's office. And in many cases, these are high-costing injectables. So we can see the trends for these drugs have also decreased in a somewhat similar manner to what we saw on the specialty drugs coming through the pharmacy benefit. So this, on the right-hand side, those drugs coming through the medical benefit, the trends went from 12.2 to 4.8. Now, overall, pharmacy costs on the traditional pharmacy coming through the pharmacy benefit represents about 18% of total costs. Now, the pharmacy under the medical benefit, that represents about 7% of total costs. So combined, all these pharmacy drugs represent about 25% of total medical spend. Now, with regards to the lower pharmacy trends that we saw this year, in addition to lower specialty trends, the insurers also pointed out other drivers, including lower utilization, better pricing, and then increased rebates. And what we're seeing in New Hampshire does seem to be in line with what's happening nationally. A lot of the PBMs reported that their trends in 2017 were some of the lowest that they've seen in the past several years. So throughout this report, all of our pharmacy data is represented net of the prescription drug rebates, but we wanted to show the how much rebates represent and how they're impacting our trends. So rebates are the amounts that are paid to the insurers from drug manufacturers, and it does help to reduce total pharmacy costs. Prescription drug rebates have grown at a faster rate in 2017 than overall pharmacy costs. So this is helping to keep the pharmacy trends down. So in 2016, what's shown on the left side, these are the pharmacy cost gross of rebates, so before we've subtracted out the rebates. And we can see that the 2016 trend was 5.8% gross of rebates, but once you take out the rebates, it's 4.8%. So that's about a 1 percentage point drop. Now looking at 17, the trend gross of rebates was 1.2, and then once you back out the rebates, the trend is that negative 0.5% that we've seen, and that's about a 1.7 percentage point difference. So this slide also gives a sense of how much rebates are worth. So in 2017, the difference between that 101 gross of rebates and the 88 net of rebates, that's about $13 PMPM. That's how much rebates were worth this year. And that represents about 12% of gross pharmacy costs. So now we're going to shift our focus to drill into the individual market and what's happening with trends there. So we saw that overall allowed claim cost trends in the individual market have come down a lot because of driven a lot by that first year of the PAP coming into the program. So the 21.3% versus now it's down to 4.9%. And we can see when you look at the different segments, it's within the non-exchange and the grandfathered transitional, which are experiencing some of the highest trends. So the 6.6 in the non-exchange population and the 9.2 in the grandfathered population. And when we dive into the information, it's driven, their higher trends are driven by inpatient facility and outpatient facility services. But we also note, when looking across all these categories, pharmacy is a large driver of trend in the individual market. And then another thing to point out, so the New Hampshire PAP population is the set of bars right in the middle. So you can see, while they're trending at a similar rate to some of the other segments, their claims level is much higher than the other segments. So they're at the 548 in 2017 compared to most of the other segments are in that 400 range. So this slide now digs into the pharmacy side of the individual market. So in the individual market, pharmacy trends were 16%, while remember back to the group market, those trends were pretty flat, or that negative 0.5%. And the individual market experienced higher trends in all of the pharmacy categories compared to the group market. But as was the case in the group market, we also saw the trends come down a lot in the specialty pharmacy in particular. They were trending at almost 37% last year, and now they're down to 14%. Now, when comparing PMPM levels between the individual market and what we saw in the group market, that the individual market PMPM, that 108, that's about 23% higher than what's happening on the group market side. So while overall pharmacy trends have come down even in the individual market, they're still very high at 16%, and the pharmacy levels within the individual market are still much higher than what's happening on the group segment. And I should also point out, so this actually excludes the PAP population, but when we look at the pharmacy costs for the New Hampshire PAP population separately, they have very similar pharmacy costs to the non-PAP population, but their mix of drugs is different. The PAP population is actually using more non-specialty, brand non-specialty, and they're using less specialty than the non-PAP population. So the last two slides in this section looks at two key utilization metrics. One is inpatient admissions, which is what is shown here, and the second one we'll look at is emergency department use. So overall inpatient admission use has increased in New Hampshire and within most segments, except for that large group fully insured segment. And another thing to note is the New Hampshire PAP population, you can see they have much higher inpatient admissions rates than the other segments. While if you look at the individual population excluding PAP, their inpatient admission use is actually pretty much in line with the two group markets. And that line in the middle, we're using it as a benchmark point. So that's data coming from the Healthcare Cost Institute. So the most recent metric we have for them is from 2016, where they show in the group markets across the whole U.S., admits are about 50 admits per thousand, which you can see the small group market is pretty much in line with that, and the large group market is slightly higher than that. So lastly, this slide shows emergency department utilization. So one very positive thing across the board, we've seen emergency department use decrease in every segment. So overall, it's decreased 5% during this time period. But you can see the New Hampshire PAP population does have much, much higher emergency department use than the other segments. So the last section we're going to look at covers some information related to medical loss ratios, expenses, and profits. So first off, we're going to start and talk about risk adjustment. So the risk adjustment program, what it generally does, it redistributes funds from insurers with lower risk or healthier enrollees, and it transfers money to those insurers who have sicker or higher risk enrollees. So health plans who have healthier members will end up paying, and those amounts are shown in red, versus the health plans who have sicker members and end up receiving money are shown in black. So this was the risk adjustment program's a permanent program under the ACA, and it's revenue neutral under the New Hampshire individual market and then separately within the small group market. So in the individual market, we can see, so Minuteman was assessed a $39 million payment for 2017 risk adjustment, which means they attracted much healthier risk than the other insurers in this market segment. But as a result of Minuteman's closure at the end of 17, risk adjustment payments from Minuteman to other insurance carriers is not expected to happen. So what does this mean for the other insurers? So as a result of the other insurers not getting their risk adjustment payments, they will all experience lower profit margins than they otherwise would have. So risk adjustment payments in 2017 for the individual market, it was expected to represent about 6% of premium for Anthem, Matthew Thornton, 11% for Harvard Pilgrim, 13% for Ambetter, for a total of about 10% of premium. So as a result of the non-payment, when you look across all these three individual insurers, on average, the profit margin is it would have been around 7%, and now as a result of the non-payment, it's about -3%. So we looked at the data earlier to show Minuteman's impact on enrollment in the market. So this gives a picture of the Minuteman's impact to other insurers in the market. So now this focuses on risk adjustment in the small group market. So in the small group market, the new market entrant Tufts will end up paying about 50% of the total risk adjustment within the small group market, so the $3.3 million in red, and Harvard Pilgrim will end up receiving about 81% of the risk adjustment payments, so they're shown the black, the 5.1. So this would suggest that Tufts attracted the healthier risk in this segment, in this time period, while Harvard Pilgrim attracted the least healthier risk. Now this looks at medical loss ratios within the group markets. So the percentage of premium that's paid for medical and pharmacy is about 85% in the small group market and 80% in the large group market. The profit margin in the small group market is about 3%, which is shown in purple, and that's very similar to what we saw last year. In the large group market, their profit margin is 7%, shown in purple, and that's a slight increase from what we saw last year. Last year it was 6%. So lastly, we're comparing loss ratios for the large group fully insured versus the large group self-insured. So we saw on the previous slide, in the large group fully insured segment, their loss ratio, meaning the percent of premium dollars that are spent on medical claims, medical and pharmacy claims, is 80% versus 93% in the self-insured market. So that's a similar relationship to what we've seen in the past. And as we were discussing earlier, so insurers in the fully insured market need to retain more of the health insurance premium because in addition to administering the benefit, they're also taking on all the risk of paying those medical and pharmacy claims. And also generally, self-insured accounts are much larger, and there's an economy of scale that's recognized that allows insurers to charge a lower admin fee to the larger self-insured accounts than they would to the generally smaller fully insured accounts. So a lot of information, but what we felt like were some of the key findings and key takeaways was that the individual market is shrinking in 2018, and Minuteman's closure is impacting insurers and the market in 2017 and then even beyond. Individual market rates are decreasing in 2019, but they're still significantly higher than the rate levels from 17. Individual market members who do not receive subsidies have the highest deductibles and they're paying the most in out-of-pocket costs. Now on the group side, we have seen that premium trends and claims trends are slightly higher in 2017 than 2016. The large group self-insured market represents close to 50% of the total commercial market, and they have much lower cost sharing and also higher claims levels than the other segments. And pharmacy trends are lower than what we've seen in previous years, driven by much lower specialty pharmacy trends. But in the individual market, we're still seeing that high pharmacy costs and pharmacy trends. So the full report is available on the website, so that gives even more detail and context around all of the information we presented. And I just want to thank again everyone on the NHID staff for all of the information and support, and all the insurers, many of you who are in the room, for all the information that you provide to put this together, along with the other stakeholders involved in this process. So at this point, we're going to open it up to questions from the audience. And I think you can just, raise your hand. And
So on slide 24, you talk about what members out of pocket, members cost share. Are those actually what's being attributed to the members? You used the word paid. Are they actually paying that? How much of that is being borne by bad debt on the part of all the providers?
it's my understanding the way this is reported to us, this is actually what's being paid by the members. I don't know if, would you just, okay.
That's true.
Yeah.
That would
So-
be in there.
So the part that's eventually going to bad debt on behalf of those people who aren't paying the cost they're incurring, do we have any idea what's happening in that trend?
We didn't have the slide here. We do work with DHHS and the Hospital Association to collect information on uncompensated care costs, and one category within that bucket is bad debt. And it's actually in our report in the appendix, but I don't have that slide here, and I'm not quite remembering what we saw in that category, but we've tracked that over time, and we show what that.
And that's for the hospitals, but it doesn't
Yes.
count for any of the other providers.
Right,
Okay,
right,
thank you.
yeah.
When you were looking at, thank you for this presentation. Excellent job. When you were looking at deductibles, did you look at how many deductibles include prescription deductible in the deductible payment, and would that impact the prescription drug trend? So do you know what the trend is for out-of-pocket pharmacy?
If you were to just look at the pharmacy deductible? Well, I guess what we found, it's actually very challenging to separate out medical versus pharmacy out-of-pocket costs, because so many deductibles now apply to the full spectrum of cost. They're not I think it's more rare that there's a separate medical and pharmacy deductible, or there's just a big mix, so we can't really track that separately. So this is just one component of cost sharing, but this just represents, I think I'm looking at Don, this is the deductible that, it's the single deductible on the policy. So it could cover pharmacy in some cases and it may not, but I think most likely in many cases it covers pharmacy. So I know that probably doesn't really answer your question, but it's difficult to it's very difficult to separate out-of-pocket costs for pharmacy versus medical when in today's world so many deductibles are integrated over both benefits.
I have a question from the live stream.
Oh.
Somebody asked about the contributors to trend slide.
I don't remember what that is.
The outpatient facility sites was listed as 40%, but what percentage are hospital out-of-patient departments versus ambulatory surgical centers?
That I do not know. We don't collect that level of detail, so I cannot answer. I mean, yeah, I don't. Some of the insurers might, folks that have a little more access to more detail might have some more information. But AMP Surge is obviously a big portion of outpatient facility bucket. So I guess you could suppose that. It's got to be one of the drivers, but I don't know enough to say how much. Oh yeah.
Yeah, on that same slide, for inpatient facility, are there pharmacy costs wrapped up in that piece?
Yes, the way the pharmacy costs come through on the medical side, they could be showing up in different buckets depending on where they're administered. So yes, pharmacy could be embedded actually in almost all of the pharmacy on the medical side can be embedded in a lot of these categories.
So there was a slide early about the exit from Minuteman and so the folks who we assume just exited the market based on that one.
Yeah.
So just out of curiosity, I think you said that was based on the CHIS data, and so I'm assuming that you were sort of looking to see if people who were and Minuteman subsequently became enrolled in other plans. Not that it's a huge number likely, but I was just curious, is it possible that some of those folks may have gone to some of the small insurers that don't contribute to CHIS because they don't meet the thresholds?
Yes.
So there might be some coverage there that's in just small plans that we don't see. Is that
Yes.
right? Okay.
But I think, I know from the data we collect, I don't know offhand for CHIS, but within our data we collect, I want to say upwards of 98% of the total market. So I imagine CHIS is probably very similar, but yeah.
A little bit of
Yeah.
coverage could be happening in places we can't see.
Yeah.
Yeah, so it looked like you concluded that a large part or the majority of increases in rates was due to cost and not so much mix or utilization.
Yeah.
Have you looked at the state's ABCD data that they collect and looked at variation in cost for negotiated rates across providers and seen what kind of savings potential there actually is if you assume that utilization is, it looks like utilization is going down. Yeah, we're still paying more.
You mean the impact of provider price variation across?
Yeah, this hearing annually, the commissioner is saying that we're supposed to be looking at drivers of cost and figuring out why rates are going up.
So we do not have that data right here, but I know New Hampshire has done other studies looking at provider price variation. I don't know when the most recent one was, but I can speak to work in other states. Provider price variation is definitely a key driver of cost, and I think it's
Over 40 or 50%.
Yeah.
Savings potential if you look at it.
If everyone were to move to the
Yeah,
same, which
that's
is not
all-
really
yeah, no, that's not
ever
realistic. I'm
practical,
just
but
talking about,
yep,
absolutely.
yeah, just as a, yeah.
If you realize 2% of that, this looked like a down.
Mm-hmm. Okay, I think, oops, Oh, sorry.
I just wanted to dovetail on what he's talking about. Providers in the state are, somewhat regulated in what they can charge, but no one's looking at the allowed amounts that these insurances are claiming are reasonable. We have insurances that are paying us under Medicaid rates and trying to tell us that it's based on marketplace. We can't possibly survive to take care of patients if we can't get a reasonable cost to even cover giving that service. And I think a big part of this is not attainable and it's not affordable. Everyone's forgetting the point that this is happening because people do not have the money. So when you're talking a $3,000 deductible, $5,000 deductible, and then you're talking hundreds of dollars for co-pays every month for medicines, especially ones that are for chronic conditions, how reasonable is that? It just doesn't make any sense. And no one's looking at what the insurance's responsibility is. We're always looking at making sure they get profit. I'm not against them having profit, but reasonableness where we all are working together. And it does not feel like that's what's happening. The patients are getting less and less, providers are getting less and less. I just feel like we're missing that whole component.
I mean, I think the panel that's coming up later, I know it doesn't address everything you're talking about, but I mean, one of the main goal of the panel is to talk about provider consolidation, which is one area of concern and possibly impacting prices. And, I think that would be, maybe something that the panel can touch on, or you can bring it up at that point as well. Okay, I think I'm going to turn it over to you.